So firstly, I would like to acknowledge the Bedegal people of the Eora Nation, who are the traditional custodians of the stolen land from which I'm speaking. And I pay my respects to the elders, both past and present. And I also extend that respect to any Aboriginal and Torres Strait Islanders who are here today. It's really important that we acknowledge that this land has been land where knowledge was shared for thousands of years. It's really great to welcome you all here today for this exciting seminar, Why Trust Digital Health, Understanding the Perspectives of Communities Affected by Blood-Borne Viruses, STIs and Social Stigma. We're lucky enough to have three wonderful speakers today. James MacGibbon, who is a social scientist and PhD candidate here at CSRH, researching health, sexuality and intimate relationships. Anthony KJ Smith, who is a Scientia PhD candidate and research assistant at CSRH, researching clinician perspectives on providing PrEP in Australia. Anthony's research interests include HIV prevention, health sociology and qualitative research methods. And Christy Newman, who is an associate professor at CSRH. She contributes to the program of social research on sexual and reproductive health, blood-borne virus prevention and care, and sexual and gender diversity. And I'm Claire, I should probably introduce myself first, and I'll be chairing. So today they're going to discuss key findings from a national community survey and key informant interviews conducted in the Trust in Digital Health study. The study was a partnership between the UNSW Centre for Social Research in Health and community organisations that were representing people with HIV, sex workers, gay and bisexual men, and trans and gender diverse people in Australia. So take it away, guys.
Thanks very much, Claire. Christy here. I'm joining you all from Gadigal land today. We're going to be doing a kind of a joint effort here, as Claire's mentioned. James managing the slides. So if I say next slide, please, that's why I'm doing that. And as mentioned, this is a real collaborative effort. All of our research is at the Centre for Social Research in Health, but this one was a remarkable effort and a combination of energies through a really difficult year for most of us, I'm sure. I just wanted to, before we start, recognise that the key partners on this national project were the National Association of People with HIV Australia, Scarlet Alliance, the Australian Federation of AIDS Organisations, the National LGBTI Health Alliance, and ACON's program on trans and gender diverse health equity. And we also received a whole lot of support from many other organisations in recruitment. I'm not going to have time to recognise everybody for their work, but I just wanted to start there. So, beg your pardon, James, can I have the next slide just so I make sure I know where we're at? Yep, I'm going to be covering some of the background to the study, and then I'm going to introduce you to Anthony, who's going to talk about the key informant interviews, and then James, the survey, and then I'll wrap up. And I'm going to try and do this all very quickly. So to start, I wanted to, I think it's next slide, please, James. Yeah, great. Just to talk a bit about what we mean by digital health. So I'm sure we all know that we all have access to a very wide range of digital technologies today, which have some benefit for the promotion of health. So in our research, what we're taking that to mean are, for example, electronic health records, mobile apps that collect data relating to health, social media sites for sharing information, accessing information to do with health, wearable devices, online forums, and virtual health or telehealth consultations. And we know that these have become a key part of the landscape for healthcare and health promotion in recent years. And the promise of these technologies and platforms is extensive, often summarised though as offering the potential for a more effective, more efficient, more integrated health systems, which can reduce medical errors, streamline services and inform more targeted population health responses. And so digital health has very much received attention and resourcing from governments in recent years. It's an important policy priority for the Australian federal government, demonstrated through major investments such as My Health Record, the National Electronic Health Record System, which had the aim of creating a record for every Australian. And so in addition to improving health system efficiency and streamlining healthcare delivery, My Health Record is aimed to provide users with greater oversight themselves of their healthcare, to help them make medical decisions, share health information with all providers involved in their care. But despite extensive government investment to expand digital health, there's been very little research conducted on community views of these systems, and in particular, almost no attention to the perspectives of...
Hey, give me...
Oh, somebody, nope, mute everybody, please. Very little attention paid to the perspectives of those populations who are prioritised in the national response to bloodborne virus and sexually transmissible infections. And so that's the background to this project. And we believe, next slide, please, James. We believe that this lack of research is a particular problem because the promise of digital health needs to be available to all of those living in Australia. And we also know there are many good reasons why particular communities may be reluctant to put their trust in the safety and the quality of digital health systems. And trust is really important to think through as a concept for capturing some of what shapes the relationships between communities, institutions, and systems in this increasingly complex and interconnected world. We know that that trust, a common, sorry, I've distracted myself with my too many notes. A common understanding of trust, this is the way we kind of understand it every day, is that it involves a firm belief or confidence or faith in the reliability, truth or ability of someone or something to come through for you. And in social research, trust has been described and explored in many different ways, but one of them is as a sort of glue that holds society together, making it possible for us to go about our daily lives, having faith in others and in institutions, rather than living in constant uncertainty. But we also know trust can no longer be assumed. It is conditional and it has to be earned, negotiated as a quality of relationships over time and in specific contexts. And digital health systems, which often require people to share information, personal information that people may be concerned about sharing, and sharing those in abstract or remote systems. And this has the potential to complicate and intensify the important question of what conditions need to be met in order to earn and sustain community trust. Next slide, please. So as I mentioned, there's a lack of an evidence base to inform Australian digital health policy and practice, and this reduces the potential for all communities to benefit from this the promise of digital health. The national strategies for the prevention of bloodborne viruses and STIs, I've got two of them here, include strong commitments to improving services which rely on digital health infrastructure such as partner notification systems, improved patient management systems, increased integration, linking and coordination across care systems. So we think it's been a real missed opportunity to understand how the populations prioritised in those strategies feel about engaging with those systems. And there are a range of different populations prioritised in these strategies, and we've mentioned 4 at the beginning. So those are the 4 that we have prioritised in this project, which was an exploratory pilot study, because it's a very big task to engage meaningfully all of the populations which are prioritised in these strategies. So I'll talk a little bit more about that in a moment. Next slide, please. So the Trust in Digital Health study is what we called it as a shorthand, is conducted as you heard before between our centre and those key organisations. And it did include 2 major methods. One was a national online cross-sectional survey, and we had specific recruitment targets for the 4 priority populations. We also conducted semi-structured interviews with key informants with expertise in a broader range of communities. Unfortunately, we don't have time, of course, to go in depth into all of these methods and all of these findings, but please do have a look at the report which is published today, which does provide as much detail as we could on what we did, and particularly the range of reports that we're able to generate from the survey. And also next year we plan to have some peer-reviewed papers available, and please let us know if you'd like more information about that. Next slide, please. So just before we get started, I just wanted to give a few caveats and context. So our study was funded by the Australian Government Department of Health, but it was conducted entirely independently by our team with input from our community partners. Very grateful to these partners. We would not have been able to do any of this without them. They really helped us design a very useful survey from scratch and conduct interviews with the right experts. The timeframe was very tight and made really complicated by the impacts of COVID. And so please do recognise that this is exploratory. We hope that it will lead to future more targeted research also. And also just noting that, you know, there are populations who were not well represented in this survey, particularly people who use illicit injecting drugs, who are a really important community to think about in terms of this topic area. We have got little bits of findings we'll share in relation to those, but we recognise upfront that we weren't able to cover all of the priority populations we would have loved to if we could, with a longer time frame. I think they're the main things that I'll say. Just briefly on the survey sample, we did recruit a general population sample, and of that, there were a proportion who fit the criteria for membership for one or more of the priority population groups. So results, when they're presented, are separate for those priority populations because there's little value in collapsing them altogether. Some participants were members of more than one, but frequencies and proportions are reported for each. They shouldn't be read as comparative to each other or as comparative to the general population sample, and James will talk a little bit more about that when he starts. But to begin, I'll hand over to Anthony, who's going to be talking about the key informant and interviews. Thanks, Anthony.
Thanks, Christy. So my name's Anthony, my pronouns are he, him, and I'll be presenting on the key informant interviews. So I'll just go to the next slide, thanks. So we conducted one-on-one semi-structured interviews with key informants who represented or worked with some of those main 4 priority populations. And so participants were selected for their expertise by the team and invited via email. So 16 participants were interviewed by Christy between March and June 2020 by telephone or Zoom, and the interviews lasted on average about 48 minutes. So in the interviews, we got participants to define digital health, however they saw it, to define what they meant by trust. We got them to explore risks and benefits of digital health for the different priority populations that they had expertise with, and the factors that shaped trust for those populations as well. And we also asked them about potential mechanisms that could improve trust in digital health or improve digital health systems themselves. I coded the data and conducted a reflexive thematic analysis following Brown and Clark's approach, which basically involves looking for patterns of meaning in the data. I'll go to the next slide. So of the 16 participants, they were relatively younger sample, but they were highly professional. So they've been working in the sector for an average of 16 years, between 6 and 32 years. They held various expertise with those 4 priority populations, but also one of the benefits we have here, which we don't with the survey in terms of the recruitment, is that 6 of those participants also had a lot of expertise with people who inject drugs, people who use drugs. A smaller proportion too held expertise with young people, and 1 participant held expertise with Aboriginal and Torres Strait Islander people. Participants primarily worked in peer-based non-government organisations, but also university, consultancy and healthcare. And in their work, their roles included advocacy, but also education, policy, research, and a smaller proportion engaged in health promotion. Participants were diverse in sexuality, so 5 were queer, 4 were gay, 4 were bisexual or pansexual, and 3 were straight. And they're also diverse in gender, so 7 reported their gender as a cis woman or female, 6 as a cis man or male, 2 as non-binary, and 1 trans man. But participants were primarily of Anglo, Irish or European heritage. A smaller proportion had Asian or Pacific Islander heritage, and 1 participant was Aboriginal or Torres Strait Islander. And they were a highly qualified group as well, so 12 participants held a postgraduate qualification. We'll go to the next slide. So we got them to define digital health. The primary focus across the interviews was really on electronic health records, and particularly the My Health record, which is not surprising given that there was so much focus on My Health record in 2018, and that many of the peer organisations representing some of the priority populations had engaged in a lot of advocacy and education around My Health record and whether or not those communities should opt out or consider opting out. But also digital health included social media and online forums, which were particularly important for some of the communities, mobile phone apps, remote or telehealth consultations, which obviously became quite important in the context of COVID, and wearables and self-tracking devices. So we'll go to the next slide. So participants indicated that there were some significant benefits for digital health. So for example, digital health could support priority populations to be better counted. So as P3 here says, there's a huge need for data linkage that can give us a better sense of how big the population is for different conditions or different demographics with unmet needs. And on that basis, from that, you get things like funding, recognition, and inclusion in research. So there was a sense in which improving digital health systems and having data linkage could actually be really emancipatory for the marginalized populations. And digital peer connections were really, really valued. So it allowed people to crowdsource answers from peers. And this type of information was often perceived to be safer, more accurate, and more appropriate than interacting with health services who might not be as familiar with the healthcare needs for some of the groups. So as P3 says, when you're newly diagnosed with HIV, sometimes it's just easier to crowdsource an answer than it is to either do the research yourself and sift through all the fact versus myth, or you're not that necessarily comfortable about disclosing your status to your doctor. So we'll go to the next slide. And so participants also tempered the promise of digital health. So P1 here says, a single electronic health record is the holy grail. Continuity of care, avoid repeated tests, avoid wrong prescriptions, etc. A no-brainer at perspective. However, when you look at it more from that of a marginalized, oppressed group facing minority stress, then it's figured quite differently. So here they indicate that it could be really beneficial for the general population, or it could offer all of these things, but there's also potentially all of these different risks. And participants were also clear that the promise of some of these systems, particularly the My Health record, hadn't really been met in practice. So P9 said, electronic health records in an ideal, perfect world where there was no stigma and so on would be perfect for our community. So for some participants, imagining that these things could have benefits required imagining living in a fundamentally different society to the one that we live in, indicating that stigma is a pressing issue, but also just that the reality hadn't matched the promise. We'll go to the next slide. So participants told us a lot about the risks, and it's important to say that some of the risks were also speculative, so they hadn't necessarily played out like the benefits, but the risks were more likely to have been things that had actually happened. They were more real. So participants described instances in which health data had already been made available to other sectors, services, or systems in a way that constituted a breach of privacy or impacted negatively on someone's healthcare. And they were particularly concerned about things like private health insurance, data being shared with employers or law enforcement. And what they indicated is that certain types of information are unsafe to be held as data, particularly if identifiable. And that's one of the big things that makes it hard to trust these systems. So as P7 here says, if you're disclosing something that relates to criminal or otherwise stigmatized activity and you have children, people are genuinely worried that being reported to child services and maybe being reported to law enforcement, like it happens now because health professionals do make such referrals. I guess it's just that unknown of who else may have access to this information, and they may exercise their discretion to take action against me. Next slide. So participants had concerns about hacking or data leakage, and they also indicated that the risks were amplified for some populations. So for Aboriginal and Torres Strait Islander people, for migrant sex workers or sex workers who were also living with HIV. So they pointed to intersections of those identities. And they were also concerned about future unknown reuses, misuses, or just uses of data. So as P11 says, I think that's what a lot of communities might be picking up on, that there isn't any forward thinking. People just develop these apps and then the government develops the apps, but then there's nothing around, okay, well, what happens, 5 months down the track? What happens if someone hacks your data? Like, what are all the safeties that you have in place to enable us to use that app safely? Like that COVID tracking app, I won't download it. And so here they were also concerned about the future uses, but also tempering the kind of optimism that you just sort of quickly develop something, throw it out, and it's going to fix these issues. So go to the next slide. So participants indicated a deficit of trust in digital health, and this deficit was shaped by a variety of factors, which included historical and ongoing stigma and discrimination for the different priority populations, the possibility of inadvertent and unwanted disclosure occurring, criminalisation of practices related to HIV, drug use and sex work, which made those forms of data fundamentally unsafe if linked to someone's identity. Systems that were binary, so forced you into a particular gender when you fill out the system, but also broadly exclusionary or requiring internet access when we know that not everyone does. The potential for data to be shared or leaked, broad concerns about privacy, and a general perception that the government is hostile and has a track record of being hostile to the different marginalised populations. So as P14 said, I think we come back to this lack of faith, lack of trust. Unless the government improve their track record and give us some reason to trust them on these matters, where like a large proportion of people are not going to download an app or opt into My Health Record. Next slide. But participants also pointed to a broader deficit of trust in healthcare, which also shaped digital health. So P9 here says, I don't think there's any such thing as full trust between patients and doctors. There are functional levels of trust, but that usually is only one-to-one. And I think the fear is when you put your trust in someone and they pass the records on or pass information on about you cunningly or wittingly to someone else. Do we owe our healthcare providers 100% transparent insight into us, into our life system? Do we really owe them that for them to do their job? They then go on to say, I cannot think of any circumstance in my life or in the lives of anyone I know that I've talked to about this, where being 100% honest about my drug use, my current drug use with a healthcare provider, where that has been a positive thing. And so P9 here indicates that the type of trust required for someone to feel like they can comfortably disclose this information, which can lead to poor healthcare experiences, is really carefully cultivated. It's one-on-one, it's with a particular healthcare practitioner or a particular service. And that type of trust is potentially incompatible with trusting an entire system to safely store your data and to protect your data. Next slide. But participants did tell us a number of mechanisms that could improve trust and could improve digital health systems. So decriminalisation of practices related to sex work, drug use and HIV would make all those forms of data much safer. Increased privacy, de-identification and protection and regulation of data. Systems that were inclusive of gender diversity and more accessible and equitable. And robust consent mechanisms, so exploring the potential for consent to be specific, informed and dynamic in all sorts of different ways. So here P6 says, it's important to make the distinction between the collection of data and also the informed and appropriate analysis of data. That's where trust comes into it. How that data is used, whether there are adequate parameters around ensuring that our right to privacy is embedded and confidentiality is respected. Next slide. And participants also wanted to see increased consumer and community engagement. So they saw community organisations as being able to broker meaningful engagement to ensure that digital health is safe and acceptable in the stage of development, but also in implementation. So if community organisations were funded to do these types of things, that could be a way of reaching some of the priority populations better. And they're also clear that any engagement needs to be meaningful. So as P2 says, I think consumer engagement can't be tokenistic. We have a number of examples where through the consultation process, consumers are heavily engaged, they're given really strong feedback, and then things have gone in the complete opposite direction despite all the feedback from consumers. And they go on to say, you know, what's the point of engagement if you don't take on the advice? And next slide. So to conclude on the key informant interviews, and there's much more there in the report, participants indicated that investments in digital health could have some significant benefits for marginalised populations. They could be really transformative, they could be emancipatory, and they did really want to see these things be done right, because because they work for these communities and they want to see the health of these communities improve. But trust in digital health is shaped by histories of discrimination, stigma, and criminalisation. Therefore, decriminalisation, reducing discrimination and stigma, could increase trust in digital health, but also there need to be investments in meaningful consultation, consent mechanisms, law reforms such as around privacy, and those things are all necessary for ongoing and future innovations in digital health. And so these findings from the key informant interviews support slow, cautious, informed, and consultative implementation of digital health systems, as opposed to that kind of techno-utopian optimism of just sort of developing a new app that's going to fix the next healthcare problem. So I'll finish there, thanks.
Thanks so much, Anthony. And now we're handing over to James, who's going to talk to us about the community survey.
Great. Thanks, Christy. All right, and thanks very much, Anthony. Really great outline of the interviews. So as Christy just mentioned, I'll be running through some of the key results from the community survey, which we launched in April, in the early weeks of the pandemic, which was a very interesting time to be launching a survey, of course. And that was open until toward the end of June. We recruited 2/3 of the participants using a panel research firm, which was Qualtrics, and the remaining participants we recruited through Facebook advertising, through our social media networks, and of course through the mammoth effort from our community partner organisations, who had a particular remit to help meet our targets of the priority populations that they represent and work with. And as Christy's outlined, these were the 4 groups from the national strategies: gay and bisexual men, trans and gender diverse people, people living with HIV, and sex workers. So moving on to the sample characteristics, we had a little over 2,200 participants, and they were aged between 18 and 87, with an average age of 40. About half described their gender as female, most were cisgender, and of the trans and gender diverse participants, 16% were trans men, 27% trans women, 43% non-binary, and 13% used a different term to describe their gender. Back to the entire sample, most identified as heterosexual, about 1/3 were employed full-time, almost half had a university degree, and again, nearly 1/3 were members of one or more priority population groups, and of the whole sample, 20% were members of just one priority population group. We used quotas so that our recruitment was representative of the Australian states and population data, and we had a slightly younger sample compared to ABS data, but otherwise, even spread spread across the states and territories, and also in gender. Now, as Christy mentioned earlier on, we weren't able to compare the groups using this usual bivariate approach because there were participants who were members of more than one priority population, and we did not want to condense or collapse these groups into one because we knew there'd be really important differences between the priority population groups as well as when compared to the general population, but we certainly didn't want to lose any of that detail between the groups. So we did use a series of multivariate analyses, and these were to identify independent associations between having that characteristic of being a member of a priority population group and the outcomes of interest, which we've explored in the report and we're presenting to you here. Any reference to priority populations, both today and in the report, which I hope you'll have a look at, means that the findings were significant for all of those 4 priority population groups. So including gay, bisexual men, people living with HIV, sex workers, and trans and gender diverse people. That it's not to mean that we compared all of those priority population groups together against the general population, because we did not condense those into one category. Now, as I said, we report just selected analyses here, but all the aggregated data for all survey measures is available in the survey report. Just to run through briefly as well, we had multiple sections of the report, of the survey, sorry. So there were the characteristics which I've just gone through. There were sections on health and well-being, including stigma indicators, section on trust, which included a range of questions, including general trust, but importantly, trust in healthcare services to keep information private and confidential. We had a section on My Health Record and on digital technologies and services, which asked a range of questions about the types of different apps or services that people use to manage their health or share information about their health. And finally, we had a section on how participants had changed their behaviours in response to COVID. And so I'm just going to run through the key findings from each of those sections. Now, priority populations reported more complex health needs compared to the general population. We found that they were more likely to report having 1 or more long-term health conditions. They were more likely to report that they received mental health care and that they were taking greater numbers of prescription and over-the-counter medications. The trans and gender diverse participants in our sample and people living with HIV were more likely to rate their health as poor or fair. And trans and gender diverse participants and sex workers in our sample reported the most frequent experiences of stigma, both in general and in healthcare settings. Now, turning to trust, overall, we found that priority populations were less trusting than the general population. However, there were differences between the priority populations. Looking at the whole sample though, most people did trust their health care services to keep their information private and confidential. So between 70 to 80% of all participants. And this included a range of different healthcare services. For example, GPs, pharmacy, dentist, and inpatient and outpatient hospitals. The most trusted healthcare services from these were mental health care, and general practice services. Trust in healthcare services to keep information private and confidential was much lower among sex workers and trans and gender diverse people. Well, turning to frequency of access and types of use for My Health Record, nearly a quarter of participants in the survey had a My Health Record and had actually accessed it. And another quarter said that they did have a record, but they'd actually never accessed it. And all the people who did have a record, only small numbers had accessed their record frequently. So 0.3% had accessed it monthly, 0.3 had accessed it weekly, and around 5% had accessed it monthly during the last year, quite small numbers. And the most common reasons that these people reported for accessing their record was to know what was in the record, about half of them, keeping informed, and then making sure their record was accurate. Turning to the participants who had told us that they'd opted out or deleted their My Health Record, there were nearly a third of our sample who had opted out or deleted their record. We found that the priority populations were much more likely to know about my health record, and they endorsed a few items about the potential benefits. So, they were quite engaged. They knew about what my health record was and what kinds of things they could do with it if they did have a record, but they were much more likely to have opted out or deleted their record. And this related to all of the 4 priority populations that we targeted for this research. The concerns that that people gave about my health record when they'd opted out or deleted their record were pretty similar. And that was regardless of whether they were a member of a priority population or not. And the most common concerns were that government might not adequately protect their data privacy. They were concerned about medical information being leaked or hacked, that data might be shared between government agencies, particularly without their consent, or they wouldn't know about it. And they were concerned about their personal information being used in a way that might disadvantage them. Now, finally, on our COVID items, we found that priority populations were more likely to have accessed health services differently due to COVID. And in particular, given that this survey was live during the early weeks of the pandemic, at least within the Australian context, priority populations were much more likely to report using a range of digital technologies for their health. So that was having remote consultations with medical professionals, requesting a script by phone, stocking up on prescription medications, and seeking out health information because of the pandemic. So I guess if any of these rapid findings have piqued your interest, I definitely encourage you to have a look at the report where there's much more information for you. So it's really just a taster of what's to come.
Thank you.
Hand over to Christy. Thank you.
Thanks, James. Thanks very much. And look, as James said, this is a very brief taster on, there is a lot more detail on those topics and other elements of the survey and the interviews which are in the report. And we will be writing them out also into peer-reviewed article form as soon as we can. But I guess just in closing, I wanted to touch on a few final points to bring together what we think are some of the things which are relevant to look at right across the study. James, could you do that last slide? There it is, beautiful. I think as we can see, there is useful empirical data here now that shows how and why trust is indeed a critical issue affecting engagement with digital health systems and technologies in Australia, and in particular demonstrating that some of the populations affected by or at risk of BBVs and STIs in Australia do report lower levels of trust in many aspects of the healthcare system, including digital health, despite also reporting high levels of engagement with and proactive engagement with an understanding of the promise and benefits of these innovations and of investing in the things that will help improve their own health and well-being. So we have concluded that the variety of evidence that we've been able to collect in this exploratory study suggests that trust is influenced less by issues of technical design or of digital literacy among the communities of interest, and much more by relational and structural factors which underpin trust in the institutions which are responsible for health system design and regulation. And so to address these concerns, as we've touched on, we recommend finding new and more effective ways to ensure consent is secured to collect, store and share health data, and that consent and those consent processes they are specific, dynamic and informed. Major investments in discrimination reduction strategies are required at every level of the healthcare system, which we hear about in many other contexts, but we can see here why there is that direct relationship between our communities' willingness to invest in the systems which are going to be necessary to ensure that healthcare is accessible, competent and safe for all communities. And we very much want to end on the point that resources need to be directed towards remediating the legal and policy conditions that continue to discourage some communities from participating fully in digital health systems. And also they need to be directed towards supporting meaningful consultation and ownership by peer-based organisations who have the trust of communities affected by and prioritised in the response to bloodborne viruses and STIs. So I think we'll leave it there. We've got 15 minutes left for questions, so we don't want to run too much into that time. But thank you so much, everybody. I've put the link to the report in the chat, and please do have a read through that and let us know, particularly if there are areas that you are really interested in seeing us write more on, because we are in that process now of beginning the peer-reviewed publications writing process. Thank you.
Thank you so much, guys. It's such a privilege to be able to hear these findings. It's such an exciting project. And we do have over 100 participants, so I'm sure there'll be some exciting questions. So if you could either pop your question in the chat, or you're welcome to raise your hand using the little reactions function, and you can ask your question using your actual face. So do we have any questions? Let's see. We do have a question from Curtis Chan. Now, Curtis, would you like to ask your question, or would you like me to read it out? I can read it out.
Yeah, I can ask it as well.
Great, fantastic.
Yeah, I was really curious. Really, first off, great presentation. I thought it was super interesting. You guys talked a lot about the differences in priority populations before that you were talking about, but I was curious if you looked at anything about other demographic information. So age, for example, because I'm not sure if I had to think about, would younger people be more or less likely to trust in digital health? Or, you know, Christy, you said that you don't think that it's a technological competency thing, but a relational structural thing. I'm just curious if you guys had any thoughts on that.
I think we should probably get James to make a comment on that, but my sense is we haven't done those analyses, particularly looking at the general population, but we would have probably seen if that was a key characteristic. Is that right?
We did control for demographic variables in the multivariates. So there were very small models. From memory, I'm not looking at them, but we had age in there, and yeah, a few others. And we also controlled for some health outcomes. So you know, for example, if we're looking at trust in different healthcare services, we had age, how many health conditions somebody had, how they rated their health, whether it was poor or good, and a couple of others. So we had just a very small number of variables in there that we were controlling for. And yeah, I'm pretty sure that age is in there, and that all of the multivariate figures are actually in the appendices in the report. We've been really detailed in what we've provided in there. Yeah.
Awesome, thanks.
Great question. And we have a hand up, G. Got your hand up there.
Can you hear me?
Yes.
So I do have a general, like I actually had some time in the afternoon to read through the report, and I've been seeing like you've been talking about not wanting to conflate different groups, and yet you're grouping gay and bisexual men together, where we all know from existing research there's a huge difference, and there are unique experiences of bisexual people. As example, there's a study in the UK that shows that about 68% of lesbian and 58% of gay men are out about their orientation to their GP, while only 23% of bisexuals are out towards the GP. So in your sample, you only have 39 bisexuals, which in the first place is not representative enough to talk about bisexual issues, and then grouping that together with gay men, and then saying, well, that's the one thing that's relevant for gay and bisexuals, just seems to be problematic for me. So was there any conscious efforts to reach out to specifically increase the number of bisexuals that have been participating in the study? Was there any reaching out to bisexual advocates, bisexual community groups?
That's a really good point. Absolutely, and it is an area that we should have done better with. There was a little bit of reaching out to some of the bisexual community groups, and as a member of that community, I have good connections with a number of those organisations, and I'm thrilled to see how much work is underway at the moment to try to better to recognise the problems around those when we collapse those and make assumptions about those. And I've done a little bit of exploring and discussing of that in the discussion of the report. It needs more attention. As you say, we didn't get enough in the sample as a whole to be able to do much that was meaningful there. So we really didn't want, certainly in terms of quantitative analysis, to make too much of those particular responses. I absolutely agree. Bisexual identified men and also heterosexually identified men who have sex with men, another group, again and again, there's kind of intersections across all of those. These have different ways of living, expressing and communicating a sexual practice and identity in health care context make a big are important to understand if we're thinking about things to do with trust. It is definitely an area we need to look at in more depth, and I don't think we have in this, but thank you for the comment.
Okay, we've got a question from Carla. Did you want to ask your question, Carla?
Sure, it's about communication of these results in ways that are not off-putting or alienating to audiences that really need to hear them. And we've had experiences in the past where this type of information about trust in particular has been really confronting for health worker audiences. And, we're talking about systems where humans have been involved in the designing of them and are invested in them. How can we talk about the issues around trust in digital health services or digital health systems without in an engaging way that doesn't push up the barricades straight away?
Yeah, I'll take this one again and the others can jump in if you're keen. I actually think that the findings of this study are a really useful way to engage clinicians in particular, because what we found was through both the key informant interviews and the surveys is that the trust issues here are not about individuals and their clinicians. The trust here is about the idea of institutions and systems as a whole, which are abstract and faceless, and the idea of data traveling beyond that interpersonal relationship. And I actually think that's a message which clinicians are much more likely to get on board with, that it's not their patients, their clients saying we don't trust you. It's how can a clinician say what will happen? How can they reassure people unless there's greater clarity, transparency and consultation which has occurred. I'm not sure if I'm being overly optimistic there, Carla. I agree, trust is a super complicated idea and threatening idea when achieving meaningful relationships between clinicians and service users and providers is one of the things which health professionals care deeply about. But I think what we hope is that this can provide some evidence to show that there's not an even set of relationships in the way that different members of communities relate to the social structures that regulate, that govern how we encounter health and how we practice it in relation to digital technologies. So I hope there would be a way in rather than, and potentially we can make that a slightly more nuanced message, but it's a good point. I don't know if Anthony and James wanted to add to that.
No, I just add that I think a starting place for healthcare professionals working with any of these populations and other marginalized populations is having a bit of humility that people have had some really awful experiences in healthcare settings, some of it historical, some of it ongoing, and that shapes the way, as Christy said, that shapes the kinds of ways that people trust these systems and engage in healthcare, and they don't start in the same starting place. So I think there needs to be that level of reflexivity, but I guess there's always that kind of guard up, because you want to hope that, you know, all the kind of services you provide are you know, of best quality, but it's a structural issue rather than a sort of individual, you know, this is the bad clinician over here sort of thing.
Okay, we've got a question from Ian. Did you want to ask your question, Ian?
Hi there. Yeah, I've been involved with some of these communities, and also I currently declare that I work with Beyond Blue, and we have a big interest at Beyond Blue in developing digital strategies. So I'm wondering, what are the differences that were mentioned between health services, mental health services, and mental health service providers and information, and maybe other health services? And can you say a bit more about that, and any thoughts about why there might be those differences?
James, is that something that you would want to take? What do you think?
Sure, let me just see if I can bring that up. So you're wondering if there's any detail in how the priority populations were perceiving the mental health services. I
think I misheard you. You said that mental health services were more trusted than other services. So I was wondering.
So yeah.
And was that like a large difference, or it was just quite small?
Let me just have a quick look for you.
I'll just also note that I can't remember the number, but there is a very great number of graphs, tables, figures in the report for people to enjoy, which James has worked very hard on. So there's a lot more detail there.
And I wanted to say what a great piece of work.
Thank you.
Thanks very much. Yeah, I think I'd have to just to point you back to the report. Unfortunately, I'm not sure if I'm going to be able to get enough detail, but I guess the general thing there, and my point was that mental health services, so across the whole sample, mental health services were the most trusted, shared between mental health services and followed by GPs not far behind. So a little over 80% of the total sample said that they trusted their mental health service. And these were people who had been to or used a mental health service in the past year. So I should clarify the group size there is the people who had used one of those services, and it was a little, nearly 600 people, I'd say, just eyeballing the table from the report. And the levels of trust across those priority populations, not that we can compare the proportions because some people were members in more than one group, so they might be represented twice in that table. The level of trust, it seems pretty high. So it's above 80% in all of those priority population groups, except for sex workers, where it was around 70%. I don't really have much more of a comparison for you, and I'm not sure if we actually included a multivariate analysis of that particular measure, but it does indicate that that mental health services you know, are more trusted than some of the others who had been rated considerably lower just on a crude level. So I hope that is able to answer your question.
And I think Ian's made a comment there as well. That's interesting is mental health is obviously highly stigmatized too, and you're absolutely right. This is it's a slightly counterintuitive finding that people trust in the services. They don't necessarily trust the data about them accessing services being recorded in My Health Record or in other forms. That's a slightly different point. And I forgot to mention that we have another source of data which we haven't analysed yet, which is 3 open text questions, free text questions that were in the survey, which a huge number of people completed. And one of them was about what kinds of health information are you concerned about? You know, and mental health was one of the history of mental health and accessing mental health services was one of the things that was, even from a surface reading, repeated. So we did get evidence of that, and we hope to do something useful with that free text data going forward. So hopefully we'll have more on that as well.
Yeah, and can I just add as well, I think it's important to note that this item about trust in healthcare services is whether the participants thought that their service would keep their information private and confidential. So it doesn't really extend to you know, whether they thought they'd be helpful, which for mental health services, some of these priority populations might perceive mental health providers as a gatekeeper, or you know, actually have negative experiences there, but they might still recognize that, you know, there's integrity in that in them. And yeah, I don't really want to comment on too far on what that means, but they are trusting that their information would be kept private and confidential. Key.
Yeah, and we can assume that in that case, if we're asking something like mental health services, that's a very big category. So they may also be meaning, will my psychologist keep my records safe? And that's what they're answering. So it's a sort of it's difficult to extrapolate from that. But I think we might be out of time.
Yes, we are just out of time, but we have lots of other questions, but I'm sure that everybody can access the report and see the beautiful graphs that I've heard so much about, and also the very, very interesting findings that we've heard a little bit about today. But I just wanted to thank you guys for giving up your time to speak to us today, and thank everybody for coming. And a recording of the seminar will be available online if you would like to share it, watch it again. You know, you probably want to watch it again immediately. But thank you so much for your time, everybody.
Thanks so much, Claire. Thanks, Anthony and James. And thanks everyone for coming.